Welcome, everybody. We are approaching a very critical stage of the COVID-19 pandemic, with many countries allowing people to leave their homes and to go about most of their daily life activities and to reopen their businesses. All while there is a virus on the loose, a virus that hasn't yet been contained, and a treatment that doesn't yet exist. So, was it a premature decision to relax the restrictions and allow people to go back to work? Or should we have waited for a bit longer? To answer these questions, we have an expert from the University of California, Berkeley, Professor John Swartzberg, who is an infectious disease expert and professor of public health at the University of California, Berkeley. Professor John, thank you so much for being with us.
Thank you for asking me.
So let's start with the first question. What do you think about relaxing the COVID-19 restrictions? Was it time for it, or should we have waited for a bit longer?
Well, it's not a binary decision, of course. On one end, it would be letting everybody out, back to work, back to life before COVID. On the other end would be continuing sheltering in place with very little contact with other human beings. And when you have that contact, it's always with social distancing and masks and so on. Those are the two poles. I think both are probably at this point extremes that we don't need to follow. But I think we need to be much closer to this pole than this one. That is, I think we need to be much closer to continuing our sheltering in place and to practicing social distancing when we're out than we are to just letting people back into the workplace and back to where things were before COVID. So let me explain why I think that's the case. And most of my data that I have is from the United States, although I'm pretty aware of what's happening in the other countries around the world. The data from that we have here in the United States suggests that the virus has penetrated maybe about 5% of the country. That data is not in the entire population. And that data is very poor data. So it's really more of a guess than an accurate ascertainment of the number of cases. The reason it's a guess is because we've done inadequate testing to answer that question in the United States. But let's say it is 5%. I think in some areas of the country, for example, New York City, the number could be higher. I know that data from the area of the country that I live in, what's called the Bay Area around San Francisco, the numbers are appreciably lower than 5%. But if we say 5%, it means that 95% of the population remains susceptible to this virus. We know the virus is widely circulating, and we know it goes from somebody who's infected to somebody who's not. So it would seem to me that very little has changed from the beginning of this pandemic in terms of how the virus has the ability to spread. There's a tremendous number of susceptible people, and the virus spreads easily to them. So if we're going to let people do things that will put them at risk of getting infected, it means we're going to have more cases. It's pretty simple. So we have to develop plans to allow people to get back into the workplace, to have a functioning society. And after all, if people can't work, here in the United States, we don't have very good safety nets. People will starve.
So, since you are aware of different countries, which country do you think is doing it better in terms of containing the disease?
Right. Well, I think the countries that have done it very, very well include South Korea and Taiwan as two really great examples. From the very beginning, they aggressively sheltered in place their population. They had very robust testing and a very well-developed contact tracing and identification program. And they used technology in a very helpful way to augment their contact tracing and quarantine programs. They never had a large spike. And they've been able to control the number of cases quite well.
So, were they like prepared before the pandemic, or were these short term preparations that were done quickly before the pandemic started?
Well, those two countries that I'm mentioning and a few others in Asia were hit pretty hard with SARS back in 2022, 2002, 2003. And they made the decision at that time to make certain their public health system was adequately staffed and prepared for the next pandemic. Other states did that as well, and those states that did that tended to fare much better than the United States.
So, which ones?
Well, from looking at the West, the one you're in right now, Germany, has done a much more effective job at testing.
Yeah.
Germany has followed science-based policies. They've been able to drive what we call the R naught, or the reproductive number of the virus, down around 1. Even for a few days, I think it was at 0.7 and then went to 0.9. So Germany's done a very good job, and primarily it's been centered around a population that trusts the science-based information from the government, follows it, not completely, but follows it pretty well, and has a very robust testing program and contact tracing program. That's what it takes.
And that's probably what other nations should have done from the start, don't you think?
Of course. We know we're in a situation, as I was explaining before, where the virus will continue to spread unless we take precautions. And even if we take precautions, unless 100% of people do, we're going to continue to be contending with this virus until there's a treatment or a vaccine. We have to do everything we can, and we know what we can do. So I think we have very good evidence that implementing sheltering in place and all the other things I talked about work. They're not going to solve the problem. It's not going to get rid of the disease and the agent, but it will keep it at a manageable level where we won't exceed our healthcare capabilities, where so many people won't die or be so terribly sick.
So, as reopening continues, people will go to beaches, restaurants, bars. What should these people do while being in these locations to avoid potentially spreading or catching COVID-19 infection?
They should be practicing social distancing, which means they shouldn't be going to crowded beaches, restaurants, or bars. And what I said earlier about the United States was there is no central government plan. It's up to each governor how he or she handles their state. California's been handled very well by our governor. Let's look at some other states that haven't been handled as well, in my opinion. Let's take Florida and their beaches, or Georgia, or Texas. Those states, well, let's just take Georgia and Texas as prime examples, but Florida would be another good example. Those states have not done very much testing to know how big of a problem they have. They are not equipped to do a lot of testing after they've now opened up their state. So they won't know how big of a problem they have until people start being admitted to hospitals, going into the ICUs, and getting on ventilators. Then they'll know how serious the problem is. They don't have a robust system of identifying who's infected and contacting them and putting them in quarantine. They don't have adequate PPE, personal protective equipment, for hospital staffs if there's a surge of cases. They don't fit any of the criteria that would make sense in terms of opening up a region, but they have.
But they have opened up.
But they have opened up. So what they're doing is they're putting their population at risk for this pandemic spreading widely.
So, in summary, you think that reopening is a premature decision in many states across the United States?
But again, reopening is it's a bell-shaped curve. Reopening does make sense if you have certain things in place first, and then you reopen prudently. I've listed the things that should be in place first. And then you start letting people out to work. It's like a faucet, and you don't turn it on full force. You turn it on a little bit, let some people go out. At the same time, you have a lot of testing being done to see what effect that's having. If the numbers don't go up, then you let more people out. If the numbers don't go up, you let more people out. But then if the numbers start to go up, you bring people back. So that's what I mean by prudent returning to work, prudent policy, as opposed to just opening up a state.
So this brings me to the second wave. Do you think that we will see a second wave?
Yes, there are three scenarios that models predict. The second scenario is the big second wave scenario. And it follows very much what we experienced in 1918, 1919 with the second wave, with influenza. Here's what could happen. We're in the United States right now, and frankly, worldwide, we've probably reached the zenith of the number of cases with this particular wave, and we're just either plateauing or starting to see a decline. With the summer coming up, we don't know what's going to happen to the virus, but let's assume that there are far fewer cases for whatever reason, and that's just an assumption. But if we see that, people are going to start opening up much more, turning open the faucet, letting lots of people out, not paying careful attention to sheltering in place or social distancing. And that's going to happen. And then schools in the fall or late summer, early fall will reopen. And that could set the stage for a hump or a surge in cases in later fall, along with influenza that begins around that time, that would dwarf what we just experienced this late winter and spring. So that's one of the scenarios that we talk about. Now, you'll notice that scenario is predicated upon the assumption that we're not carefully following what science tells us about how to approach this problem.
Yes.
And that's what I fear. The encouraging news is I think we have under our control to avoid that big second wave.
So from your note, I take it that a second wave is not part of the natural cycle of a pandemic. It's more like a result of the relaxed measures?
We have control over modifying this pandemic. At this point, we don't have in our control the ability to stop it, but we can modify it. That we do have in our control.
Well, this brings me to the next question. So if you were given the absolute power to decide on easing the COVID-19 restrictions, how differently would you have handled it?
Well, I'd handle it very much like other countries have handled it, including yours. I would handle it like we're doing here in California. You know, we're the most populous state in the United States. We're also geographically one of the largest. And yet we've experienced far fewer cases per capita than most other states. And it's because of following the protocols that I've just been discussing with you. I hope we continue to do that. It is obvious that there's enormous pressures on the leaders, not only of the states, but of the United States, to open up society, to let things get back to where they were. Tremendous pressure. There's lots of money attached with this. And I understand that. But our leaders have to follow science and not what they'd like the world to be like.
So the numbers of COVID-19 deaths has now surpassed 250,000 worldwide, and the total number of cases is quickly approaching 4 million reported cases. Do you trust these numbers? Or do you think that the infection is more widespread than what these numbers show?
Oh, I think the numbers are much more widespread than these numbers show.
By how much?
Well, there's the big question, and nobody knows. Again, most of the data that I have available to me is US data. And without doing a lot of both RNA testing and antibody testing, we don't know how many cases there have been. And we have to do it widely because the way this pandemic is spreading throughout the world and certainly throughout the United States, it's not this uniform spread of cases throughout the United States or throughout the world. It hits pockets. We saw that, of course, in Iran. We saw that then in Italy, New York City, Detroit has a problem here. New Orleans had a big problem after Mardi Gras. So we have these pockets of disease, and it's like a fire, multiple little large fires going on, and then embers fly from that fire, and then they start somewhere else. And that's how we see it. So, for example, some not very well done antibody studies, which tell us how many people had been infected in New York City. About 2 weeks ago, a little less than 2 weeks ago, suggested somewhere around 15 to 20% of New York people in New York City had been infected with the virus. It was not a well-done study. There were some real fundamental epidemiologic problems with the study, but let's just take it on face value. There was a study that hasn't been published yet here in the Bay Area at Stanford University and all of their affiliated hospitals throughout the Bay Area. They studied 11,000 healthcare workers, and they found that less than 3% had been infected. So we see these very discrepant numbers around the country. That's why I was saying, well, I'm going to guess at 5%, but we really don't know. So when you ask the question, how many cases have there actually been? I think in talking to my colleagues and thinking about this, I would suspect a conservative number would be that it's tenfold more than what the numbers we have.
That is a lot.
Other studies have suggested even larger. But we don't know.
Wouldn't this be a positive sign when we talk about herd immunity?
Well, herd immunity is a really problematic thing to talk about. To get to herd immunity, we'd need 60 to 70% of the population with immunity. But we don't know whether the people that are infected today, how long their immunity lasts. And there have been disturbing, albeit all anecdotal reports of people getting second infections. That they haven't been well verified, and I'm skeptical, but we have to understand that we don't even know how good our immunity is to this virus and how long it will last.
So the second infection, from what I have read recently, has been attributed to either dead lung cells or probably some traces of the virus that remain after recovery. So what do you think about this?
I think that explains a lot of it. We know that people who have had COVID-19 and have gotten over it, you can find RNA in the back of their nose or their throat for days to weeks to even over a month, and one report up to 60 days afterwards. In most of those cases, you can't culture the virus. You can't grow it on tissue culture. So it suggests that people have the test for RNA doesn't necessarily tell you that the virus is still there. So that could account for some of these cases where people have said that the relapse or reinfection. And I think it probably does.
Wouldn't it also be because of the sensitivity of the test?
Well, that's what I'm getting at. The test is exquisitely sensitive. It can still pick up RNA after the virus is gone.
So there are two types of people right now: those who say we overreacted and that we didn't need to shut down every country like we did. And then there is the other side, which says if we didn't do what we did, shutting down countries and, having stay-at-home orders, we would have seen higher numbers than the ones that we currently see. So, where do you stand?
I say look at California, or look at San Francisco and look at New York City. San Francisco reacted aggressively. New York City delayed that reaction by over a week. And look at the difference. Now, there are other explanations that would play a role as well, but the population density of Manhattan is about 25,000 people per square mile, and in San Francisco it's 17,000. So it's a much more densely populated city than San Francisco. Both cities use mass transit, although mass transit is more widely used in New York City than it is in the Bay Area, San Francisco. So there are other explanations, but I still say that we know that if you're sheltering in place, you can't spread the virus. We did not overreact.
So, what about those people who say it's just a flu? What was your reaction when you heard these kinds of
That
claims?
it's no worse than the flu?
Yeah.
They're people who don't understand how we keep how we look at biostatistics at all. Let me explain that. If you look at the number of cases that we report each year in the United States with influenza, they're not the number of cases where we've documented that people died from the flu. There are cases that are put into modeling, and we calculate how many people had what we call an influenza-like illness who died. And that's where we get to the numbers of somewhere on each year we have anywhere from 15,000 to maybe 40,000 excess deaths from influenza every year.
Mm-hmm.
But if you look at the number of people with influenza where we've documented that they had influenza and they died, that number typically is around 8,000 per year. So we've had in the United States this year about 8,000 deaths from documented influenza. Now, surely there are more, but we haven't documented those. So we've had 8,000 deaths. At the same time, we've had close to 70,000 deaths from COVID-19 documented. So that would suggest that influenza is about 10 times less likely to kill you than COVID-19.
Mm-hmm. That is very severe. So let's assume that we get a second wave. Do you think that what we did to contain the first wave will be sufficient, or will we need additional measures to deal with the second wave?
Well, what we need to be doing between now and if there is a second wave is to be prepared for it. We're doing everything we can right now, but we don't have preparation for more cases that would come with the second wave. The biggest mistake we could make, I already explained, was to just let people go back to work without any controls. But even with that, if we prepare for a second wave, when it comes, we would at least be prepared for it. That is, we would be able to have hospitals with sufficient bed capacity to accommodate those who get ill, enough ventilators to accommodate those people who need to be on them, and to have a public health workforce for contact tracing, and to have a stockpile of testing available. But again, we shouldn't put ourselves in that position. We should start planning on that now and intervening now so we never have a second wave.
Yeah. So it is preventable.
It's preventable. Yeah, remember I mentioned there are three scenarios. The second wave scenario is only one of the three, and it's the worst in terms of the number of deaths. But there are two others. One is that we don't do too much, but we do something now, and we continue to do it. And we'll have waves for the next 2 years or 18 months, we're going to experience exactly what we've experienced going through this winter with just wave after wave after wave.
Multiple waves.
Multiple waves. Multiple moderate size waves. No giant waves, but no small ones. Really do it what I have been advocating for, and that is aggressively monitor when we let people back to work. If we do that, we'll have multiple waves, but they'll be like this. There'll be multiple small waves for the next 18 to 24 months with far fewer deaths, far fewer hospitalizations. So we have control over which of these three scenarios we want to have, but it requires a national will to do that, and it requires national leadership to do that. Right now we have neither.
I think the upcoming few weeks are going to determine a lot of things in terms of how the upcoming few months will be with the COVID-19 pandemic, especially with countries relaxing the lockdowns, and this will teach us a lot of new things about where this pandemic is heading.
I do too, and I'm cautious about this summer in terms of how people react to whatever is happening.
How different your summer is going to be this year? Are you going to continue practicing social distancing?
Well, yes, I'm in the age group that is in high risk for severe morbidity and mortality. And I live here with my wife. And we have a son and daughter-in-law and 2 grandchildren 10 minutes from us that we will continue to visit, but we only visit them outside and maintaining 6 to 8 feet away from them. I haven't hugged my grandchildren or my son and daughter-in-law now in almost 2 months.
Since it almost started.
And that's the way the summer's going to be in the fall and next winter, and probably next spring and summer. On the other hand, I have a daughter and her family, 3 grandchildren back in near Washington, D.C., in Virginia. I don't know when we're going to see them again.
Maybe when the vaccine is ready.
And that's right, and that's going to be a long time.
How long?
The guesstimates are anywhere from about 12 to 18 months from now.
Yeah, but we have heard other reports of vaccines that might be ready soon. For example, Oxford, they continue to say that their vaccine could be ready by September or August.
I think that's, I hope I'm really wrong, but I think that's highly unlikely.
Why?
The Oxford group is a very good group. They've done some very good work with SARS and with MERS. So they're able to take that technology and science that they've already developed it and apply it to SARS-CoV-2. So that does give them a leg up. They're in what we call phase 1 trials now.
Yeah.
We don't even know whether the vaccine is going to work, and if it does, how well it's going to work. And we're not going to know that for a while. If things go really well, it is possible that the Oxford group would be able to tell us by the fall that they have a vaccine that works. They will not have enough people studied to assure us that it's safe. And remember, whatever vaccine we develop, we establish that's safe and efficacious is not the whole story. There are over 6 billion people on this planet. How many vials do we have to have produced? How many distribution centers will we have to create? How many people will we have to hire to distribute these vaccines? How many people will we have to train to administer them? How long is that going to take?
So creating the vaccine is just the first step, which is the tip of the iceberg.
Ironically, it could take as long to figure out the logistics of getting people the vaccine as it will take to develop the vaccine and prove that it's safe.
Yeah, but the good thing is that it's not just one vaccine that's currently being explored. There are multiple vaccines that are currently being tested. Which vaccines are you aware of? I mean, personally, I'm aware of 5 vaccines that are currently in human trials, including one in Germany and another in the US and one in the UK.
Well, I can't tick them off right now, but there are over 50 in trial and either in trial or will be in trial relatively soon. Worldwide, there are well over 150 different companies that are vying to produce a vaccine. There's some of the best minds in the world that are working on vaccines right now. I feel really optimistic that we will have one. I really do. I
Yeah.
just think the question is of timing.
When do you think we will achieve normalcy
Um,
again? You know, going outside without having to worry or wear masks, just like the same lifestyle that we had before this pandemic started. When would that happen?
Never,
Ever?
never. But don't, that's not a negative statement. Think about this. Um, I think we have been shaken to the core with COVID. And I hope that people's memories will not be too short, and that our governments will be guided by the pressure from the populations to remember this and prepare for the next pandemic. Just in the 21st century, we had SARS, we continue to have MERS, and we had the influenza H1N1 in 2009. So this is the 4th pandemic in 2000 since the turn of the century.
Yeah.
We're going to continue to have more. So when we conquer this one, which we will, we have to be prepared so that we're never in this position again.
And do you think we will learn from this lesson?
I think humans have very short memories, but I also remember that after 1918, 1919, the world changed and never went back to where it was before. And it had a lot of salutary effects. That pandemic, for example, led the way to women being tremendous, at least in the West, tremendously liberated, because so many men had died during the war from influenza. So there are, and if we look at why do we want to go back to necessarily everything the way it was before? I'm looking outside right now. It's daytime for me. The skies are beautifully blue. The particulate counts in the air are way down. When we drive to go to the grocery store or to go visit my son and his family, there's no traffic. There's no traffic jams here. Those are 2 examples of why would we want to go back to what we had before. Polluted skies, polluting our world. Traffic jams where people spend as much time in the car getting to work as maybe as almost as much as they spend at work. There's a lot that we can change for the better. I don't think we will go back to what the old normal was, and some of it was not very good.
I mean, environmentally speaking, it seems that the COVID-19 pandemic has definitely greatly benefited the planet, with air pollution going down and greenhouse gas emissions dropping across different countries. But we can't really trust that these will remain the same, because if you look from our experience with the 2008 economical collapse, economies bounced back within a record time, and all because many countries decided to increase the productivity and production levels and open industries, and this led to a spike in greenhouse gas emissions and air pollution as well. So we can't trust that it's going to remain the same for a long time.
Again, we have it under our control if we choose to do that.
Yeah, if we choose to, and that's a matter of choice. And this brings me to the next question. So, most of our predictions about the pandemic, in terms of number of deaths and cases, and projections about how many people will die by the time the pandemic ends, they come from models and simulations. So, the problem is many of these models contradict each other and they come up with different numbers every few days. So, how far can we trust these models?
I think the models are very good for very short-term prediction. 2 weeks, 4 weeks, maybe a little bit more than that. They're very good for that. But as you get further out, the models become far less predictive. So I think that they're very useful for telling us where we're going to be in the short term. And they can at least give us some hints, maybe where we're going to be longer term. But we have to understand the limits of these models. In the United States, the data that we have to put into the models is not very good. And the models are developed by very smart people, and they're very sophisticated, but they're only as good as the data that you put into them.
Yes, if I remember, in the UK, the model predicted that around 250,000 to 500,000 people will die by August, I believe. And then they updated the model and said it's 20,000. But if you look at the number of people who died so far in the UK, it has already exceeded 20,000. And similarly in the US, the numbers were higher, and then they updated the model to say it's 60,000 people who will die by the end of probably this year. And now, if you look at the numbers, it's already more than 60. It's more than 70,000 people who have died. So the question remains, can we trust models?
The model, the predictions you just quoted from the United States, that was from the University of Washington Modeling Center, which has been amongst the most optimistic of actually it has been the most optimistic of the large modeling groups in the United States. And it's received a lot of criticism, actually. They're excellent and they're very good, but they've looked at the data through perhaps rosier glasses than most other people. Just 4 days ago, they revised their model from 60,000 to 135,000.
Oh, again, they revised the model.
Correct. So again, their modeling is good in the short term. They tend to be more optimistic. Other models have been far more pessimistic. They model out of London, Imperial College in London. It was a much more pessimistic model. Again, when you use these models, look at them short term, and they're pretty good.
Yeah, that makes sense. And as you just said, it depends on what data you feed into these models. And it also depends on other factors, I believe, like testing and sensitivity of the tests and how many numbers have been reported and whether these numbers are accurate.
That's right. And once we get more testing, we'll get much better data.
Yeah. So from the research done until now, we know that the risk of death from COVID-19 is mainly based on age and the presence of pre-existing conditions such as heart disease or diabetes or obesity. And many still think that it's just the elderly who are affected, but some researchers say that the disease is shifting towards younger people as well, and that they are susceptible. So can we still move on the assumption that elderly are the main target of the coronavirus?
Yeah, it's important for us to always couch our statements with the understanding that we've had less than 4 months to really study this virus, maybe 4 months. So our knowledge about it is really evolving. And we can say this more specifically about risk factors. A lot of the risk factors that we first established were the risk factors that were identified in China. Then we learned more risk factors, and now that we're seeing more of the virus, we're even learning more about risk factors, and we're being able to refine our understanding. Clearly, age is a risk factor. It consistently shows up. What we don't know tucked into that age is other things are attendant with being older. Chronic diseases are much more common as people age. Underlying serious illnesses are much more common as people age. And how do we clean up these confounding factors with just age? For example, I'm 75 and very healthy. I have no underlying diseases. I've been very fortunate. Is my risk for mortality the same as anybody else who's 75? I don't know the answer to that question, but I'm going to bet on the fact that I'm going to try and stay healthy, because I think that will make me less likely, but I don't even know that. So we do know that younger people who have certain chronic diseases seem to die at a much higher rate. Not seem to, do die at a much higher rate. Diabetes, obesity, chronic lung disease, chronic heart problems. These are characteristic patterns. But it's difficult to sift them out because the United States is a very heterogeneous society. It's not a homogeneous society by any stretch of the imagination. And so when you try and overlay that with socioeconomic status or class, with ethnicity and race, then it becomes very complicated. So for example, a Black person in the United States has a much higher mortality rate at any age than a non-Black person.
Why?
Well, we don't know for sure, but the overwhelming data that we have suggests that it's primarily relates to access to good health care. That's probably the biggest piece of it.
Genetics? What about genetics?
There's no good evidence with genetics. It could turn out that there's some, but we don't have any evidence to suggest that, and it's not a necessary postulate, because if you take access to good health care out of the picture, we know that African Americans have a much higher incidence of hypertension, chronic heart disease, chronic lung problems, and diabetes and obesity. So why do they have that? Because those are typical what we call social determinants of health. When people don't have access to places where they can exercise easily, when they don't have access to really good food, or they have the money to purchase better quality foods, then we likely see more of these problems. So these issue of risk factors are helpful in the aggregate, but not very helpful from the individual standpoint. And we don't understand them well enough at this point.
What about children?
The incidence of disease in children clearly appears to be less. And it clearly appears to be significantly less. And this is unusual in the sense that respiratory pathogens like influenza typically have what's called a U-shaped curve, where at the extremes of age are where we see the highest mortality. And we don't see that with this disease. We see it more a line like that with age. We don't understand why that is. There are a variety of hypotheses, but we don't understand why that is. Well, I know that there's been an interesting discourse in the literature in the last couple weeks from Europe in regards to whether children get infected as much as adults, not get diseased as much. I think we all are pretty convinced that disease is not as common in children by far. And some of the European states I know are starting to resume school based upon the assumption that very young children are not particularly susceptible to getting infected and unlikely, therefore, to spread it to people who could get serious disease.
Carriers.
And they're less likely to be carriers. That's the argument that we've been hearing, that I've been reading about from a variety of, Switzerland, for example, has been promoting that idea, but several other states in Western Europe have as well. The data to support that, my opinion about the data to support that is weak. It may turn out to be true, but I don't think we have enough data to make public health policy on it yet. It's a real dilemma. People can't go back to work unless their children are in school. If their children are in school, we might see more cases, which will bring people back out of work and back into sheltering in place. I think of all the conundra in terms of understanding what's best to do, this question about school, primarily K through 12, kindergarten through 12, is probably the biggest question. How to do that and how to do it right.
Yeah, well, this brings me to the next question. Since people are going to work, you're going to be seeing a lot of them in public transport, and many spots will be overcrowded. And this brings me to the question of masks. Will wearing masks be enough, or do we need gloves, or should we also have some extra measures that we must take into account?
Well, we shouldn't be putting people in a position of being in places that are overcrowded.
Yeah, but we can't really prevent them, though.
I understand.
How we can expect them to follow rules and regulations.
Or we don't know how they'll get to work if they have to take the subway. I know both here in the Bay Area and in New York, the trains they've cut back on the number of trains because the budgets are so poor. By cutting back on the trains, it keeps them crowded, even though more people are using them. So there's an irony there. The question of gloves is the easiest of your questions. They're pretty much worthless, in my opinion, because the gloves are going to get contaminated, just like your hands will. You need to be washing your hands all the time when you touch things.
What if you're using gloves and washing your hands?
Then you're washing.
I mean, doesn't it reduce the risk by a small percentage at least?
I'm not sure how. Take the gloves off and then you wash your hands. Is that better than just washing your hands well?
Well, let's say that you go to the supermarket and you want to buy a fruit. And as you know, many people just don't really pick up the fruit at once. They need to check it and then, sometimes return it, and they don't wear masks. Gloves. So there is a potential contamination in the fruit that was just returned by someone who may have the infection. So if you have the gloves, you would think that it is offering you at least a small degree of protection, don't you think?
Right, sure. You go and pick up the fruit with the gloves on, you put it in your shopping cart, and then you take your gloves off and dispose of them. And then you go and pick up something else, a carton of milk. New gloves, put it in your cart.
Not necessarily. I mean, you wear one glove in one shopping round.
So you wear the same gloves, and then you take them off at the end.
Yeah.
And then you wash your hands.
That's right.
Before you touch your face, right? Okay. What if you don't wear gloves and you don't touch your face, and after you pick up all your groceries, before you touch anything, you wash your hands or put alcohol over your hands?
Okay. That'll be sufficient?
It should be. I'm not arguing that gloves are not a good idea. The only thing that worries me about gloves is people have an artificial sense that they're being protected. And they may be less careful about adjusting their mask or touching other things. So it's fine if you want to wear gloves, but don't think that you're offering yourself a great deal of protection. The main thing is to wash your hands. If you don't have soap and water available, then lather them with alcohol, let it air dry for 60 to 90 seconds. So that's an easier thing to answer, I thought. The masks are more problematic. The masks that people wear offer next to no protection to them for getting infected. The pores of these masks are such that the virus can get through. So the amount of protection, and you breathe, the air comes in from around it. So the evidence that they really offer protection is maybe a teeny bit.
Mm-hmm.
What they do is they reduce to some extent, and we don't know how much, but to some extent, if I'm infected and I have a mask on, it will reduce the chances of these particles getting away from me and onto you. So I think that's where there is a benefit to wearing masks when you're out in public. The problem is that people think when they're wearing a mask that they're protected, and they tend to be less cautious. They're also playing with their mask, the mask.
That's actually true. Yeah, that's actually correct. I've seen people who are playing with their masks and putting their hands outside in the outer layer of the mask, which has been shown to basically allow the virus to stay viable for up to 7 days. And there are other people who are not really fully covering the area which needs to be protected.
Right, I've seen lots of pictures of people wearing it just over their mask. I know.
That's yeah.
So,
I think.
So I think that the masks are important to protect other people, and that's a reasonable thing to do. They're not anywhere near 100% protective, but they offer a layer of protection. The major thing, again, it comes back to what we talked about at the beginning. The major thing is social distancing when you're out, and it's not always possible.
Yeah, well, but people have reached to what's called COVID-19 pandemic social distancing fatigue. They just want to leave and they want to go out.
Of course, we're social animals. Primates touch each other.
And this brings me to the next question. Based on your observation, how do you predict this pandemic will end and when?
As I said earlier, I predict it's going to be somewhere around 2 years from now.
2 years. That is a long time.
Maybe 2 years from now, maybe 16 months, 18 months from now.
Still long. And the reason for it is because a vaccine will be available by then?
Hopefully, herd immunity will work. And so one reason could be that we've achieved herd immunity, but we don't know, as we were talking about earlier, if it will work, but hopefully it will. And I'm cautiously optimistic it will. And the other hope is a vaccine. And the third hope is a therapeutic, a drug.
Which drug are you counting on?
None yet.
Remdesivir? Avigan?
Remdesivir, the published trial, not peer-reviewed yet, reduced the duration of hospitalization in sick people by 4 days.
Mm-hmm.
It did not reduce the number of deaths. There was a trend in the data to suggest that if the study had continued on, and it is continuing on, that trend would ultimately get to be statistically significant in the reduction of deaths. But the trial currently, where it stands, has not statistically significantly reduced the number of deaths.
So it's still too early to tell them?
At the best, remdesivir is going to be a drug that can be used for people who get very sick in the hospital, given intravenously.
I mean, it has been approved by the FDA for emergency use.
I understand. The FDA has approved a drug that has not gone through peer review yet.
That's a mistake?
Not necessarily a mistake. We're in the midst of a pandemic, and we've decided we're going to err on the side of being liberal with approval.
Well, speaking of the FDA, I think you've heard recently that they issued a statement warning the public from using hydroxychloroquine or chloroquine outside of a hospital setting or clinical trials. What do you think about the use of chloroquine or hydroxychloroquine for COVID-19 patients?
I think that was a good decision by the FDA, but I think it never should have come to the FDA even having to make a decision on it, because it should never have, there shouldn't have been anything more than just some clinical trials and not all the publicity about it. There was never any good evidence that it was going to work. There was clear evidence that it does have toxicity in some people. And we've seen that play out in a trial out of Brazil about 2 weeks ago. There were some serious cardiac problems with that drug.
Also France.
And France, that's right.
Yeah.
That was a drug that no one had a lot of enthusiasm about. No scientist had any enthusiasm about to start with, or very little. And everybody predicted it wouldn't be safe or effective. And it's pretty much showing that that's the case.
I mean, there isn't much talk about it these days.
Well, there shouldn't be. Frankly, there never should have been.
So we should just move on from hydroxychloroquine?
Oh, of course. Even the author of that original French paper out of France said he was only proposing it as a hypothesis.
So there was no experimental work?
Well, it was based upon some data, but we haven't been able to recapitulate that data.
And this brings me to the very last question. What's your advice to people watching this who can't wait to get back to their normal lives?
Sure. My advice is that I completely understand that I can't wait to get back to my normal life too, but that we have to let our frontal lobes dictate how we behave and not our more primitive parts of our brain. That is, we have to use our intellect now. And we have to understand what the problem is. We have to understand what we can do that works, and we have to follow that, as opposed to what we want. You know, we all have two voices talking to us, what we want and what we know. And we have to let the voice of what we know dominate how we behave. You know, we're responsible to ourselves, but we're also responsible to our fellow person. If I get infected, it could kill me. If I get infected, I could infect my wife and my children and my neighbor, or the person down the street who I don't even know, who we spend time with. So we have a lot of responsibility as individuals.
So we should be careful and care about each other.
It's the only way we can survive on this planet.
Yeah. So, well, let's hope that the upcoming few days will bring good news for the COVID-19 pandemic. I mean, with the numbers going down across multiple countries, you've got Spain, Italy, the US is catching up, and France.
And Iran too.
And Iran too, if all the reported numbers are accurate.
If they are accurate.
So, Professor John, thank you so much for being with us today, sharing your insights about the COVID-19 pandemic and also tips on how to deal with the pandemic, especially that many countries are now relaxing the COVID-19 restrictions. Thank you for sharing your insights, and this was very helpful. Stay safe and take care.
You're welcome. You're welcome. Thank you.